Awesome. Thanks so much, Dr. Chow, for the introduction. Honestly, it's really nice to be able to present at these rounds because I've learned already so much from watching the kind of the echo rounds from the last couple of months as I've been here. So hopefully I'll be able to do the same. So the purpose of my study and my presentation is to look at the diastolic function guidelines that were published last year. And the whole purpose of this is to really review the physiology and the phases of normal ventricular filling. I'll try less so to focus on the nitty-gritty, but just to provide a broad framework on how to kind of view diastolic function and how to understand the physiology, which kind of translates and correlates to the guidelines themselves. I want to describe the conventional and emerging echocardiographic parameters used to assess diastolic dysfunction, and then also highlight some of the key pitfalls in assessing diastolic dysfunction. And then finally, I'll quickly go through some of the changes that were made in the most recent ASE EACVI guidelines compared to the 2016 guidelines. What I won't be talking about during this presentation is the technical sort of aspects of acquiring all these images. And certainly I have a lot to learn from my echo tech sort of colleagues in terms of how to actually get this done properly. So in terms of normal ventricular filling, it consists of 4 different phases, and I'll just spend a little bit of time going through this. It consists first of isovolumetric relaxation, where there's the interval between the aortic valve closure and also the mitral valve opening, during which the left ventricle pressure falls rapidly, and there's no real change in the volume. After that, you have early rapid filling, which is driven by the pressure gradient between the left atrium and the left ventricle relaxing. This generates the E wave on Doppler imaging, which we'll talk about a little bit earlier. Following this period, there's a period of diastasis where the pressure between the left ventricle and the left atrium are relatively similar. And so because of this, you have a relatively slow period of filling. And then finally, you have the atrial kick or the atrial contraction, which generates the A wave on our mitral CW. Diastolic dysfunction itself reflects an inability for the heart to fill at normal filling pressures. And this is something that we'll see kind of as we go throughout the presentation. When the filling pressures must rise in order to maintain the stroke volume as well as the cardiac output, this is one of the hallmarks and one of the true definitions of diastolic impairment. Now, diastolic function in general is going to be dependent on 3 different properties. And I like to break it down into kind of the active ATP-dependent process, the inactive non-ATP-dependent process, and also the kind of parameters of the patient itself. So the myocardial relaxation in general is an ATP-dependent process that involves the calcium uptake in the sarcoplasmic reticulum. And this occurs relatively early on during the diastolic cycle, specifically during the interventricular or the IVRT section. The second determinant is the myocardial stiffness or the compliance. This is more so an intrinsic property of the myocardium itself, and it's determined by factors relating to fibrosis, relating to scarring, previous coronary artery disease, as well as infiltration, which I'll go through kind of during the next slide. In general, one of the key highlights to understand is that a stiff ventricle generally requires a similar or a higher degree of pressure in order to create the same degree of filling. Thus, we're actually shifting the diastolic pressure volume curve upwards towards the left. And finally, the third determinant is sort of the loading conditions. And this one involves preload, involves afterload, and drives heart rate as well. And unfortunately, this preload effect is kind of what limits our ability to use one single echocardiographic parameter in order to determine diastolic filling. So in terms of the causes of diastolic dysfunction, I won't spend too much time on this. In general, I like to break things down into both cardiac and extracardiac causes. So on one hand, there's issues with the myocardium itself. So we think about hypertrophic cardiomyopathy, we think about infiltrative cardiomyopathy, and then also increased load that's put on the cardiac tissue, resulting in changes to the cardiac myocyte function, specifically things like hypertension and then aortic stenosis. And then long term, we also know that coronary artery disease can cause increasing diastolic dysfunction before it even causes systolic dysfunction. And so that's always something that we're looking at in our patients. And then one important consideration as well is these extracardiac manifestations as well, specifically pericardial disease and things like constrictive pericarditis. We'll talk about this a little bit later on, but pericardial disease is one of those excluding factors in the most recent 2025 diastolic guidelines that sort of causes us to actually have to use additional parameters in order to assess diastolic function. So, next we're going to talk a little bit about the key echocardiographic parameters. And there's, 6 or 7 of them that are really important. I'll go through each one of these in detail, specifically the mitral inflow pattern, the TDI at the mitral annulus, the pulmonary vein inflow, the IVRT or the isovolumetric relaxation time, The left atrial reservoir strain, which is something that is kind of more common in the last, 5 to 10 years, as well. What I won't be talking about quite so much is your left atrial volume index, as well as the peak tricuspid regurgitation velocity. What I'll just quickly note is that the LAVI, or the left atrial volume index, correlates generally with increased LV filling pressure over time. And the number that we look for is greater than 34. Now, in general, this is a relatively, common marker, but can be also influenced by a variety of other conditions. Specifically in those patients with anemia, for example, they're known to have increased atrial sizes that are kind of not directly related to the myocardial properties. People with heart transplant can get allograft dysfunction and also an associated atrial dilatations. People with arrhythmias, as we see very, very often, have dilated left and right atria as a result of those reentrant circuits that have occurred long-term in remodeling of the atria. And again, that's also independent of the diastolic function. And then obviously valvular diseases, as we see quite often in St. Michael's Hospital as well. Relatedly, the peak tricuspid velocity is also one that I won't spend as much time talking about, but in general, it's thought to correlate with your pulmonary artery systolic pressure and your left atrial pressure over time in the absence of RV outflow tract obstruction or pulmonary disease. And this is relatively straightforward, but again, we also have to rule out kind of intrinsic properties or intrinsic issues with the tricuspid valve that we oftentimes see here at St. Michael's Hospital. The number that we're looking for in this situation is greater than 2.8. So first of all, I'll talk a little bit about the mitral inflow pattern. So the peak E wave, first of all, represents the early pressure gradients between the left atrium and then the left ventricle during early diastole. And the way that I like to think about it is sort of this is the suction phase, where the increase in ventricular relaxation generally creates a pressure gradient that pulls blood into the atrium, into the ventricles from the atrium. In general, the E wave is thought to correlate relatively well with filling pressures in people with reduced ejection fraction. However, in preserved ejection fraction, the E wave correlates relatively poorly because it can be influenced by left atrial pressure and also the rate of ventricular relaxation as well. This dependence on preload oftentimes limits its utility in isolation, and I'll talk about this in the next slide, or one of the next slides. In contrast, we also have the peak A wave, which reflects the pressure gradients between the left atrium and the left ventricle during late diastole, and it's generated by the atrial contraction or the atrial kick. In general, the interpretation becomes unreliable, specifically in sinus tachycardia, because in this situation, we actually have a shortening of the diastasis phase, which we know is most affected in people with tachycardia. Similarly, it can also be affected when its interpretation is also relatively challenging in people with a first-degree AV block, because the duration between the P wave and the ventricular sort of contraction is so prolonged, such that the ventricular contraction actually encroaches on the subsequent A wave in the subsequent cardiac cycle. In both situations, what tends to happen is that we have a fusion of your E wave and your A wave, such that the A wave becomes actually abnormally high, and we actually end up with a grade 1 or a grade 3 diastolic sort of pattern, which I'll talk about a little bit later. The final situation where oftentimes your A wave can't be used is obviously in atrial fibrillation and also atrial flutter, because the A wave is almost entirely sort of uninterpretable. So when we combine these two factors together, we have the E to A ratio, which integrates these two measures and generally is used to characterize the overall filling pattern. But again, because of the inherent limitations of both the E wave as well as the A wave, which I've talked about before, we have to use other parameters as well. And in general, in both situations, it's not directly sort of representative of the degree of diastolic dysfunction without kind of looking at other factors. Finally, we also have the deceleration time, which measures the time interval between the peak of the E wave to its return back to the baseline. This generally reflects the interplay between the left ventricle relaxation, the chamber stiffness, and also is dependent on preload as well. So a prolonged deceleration time suggests impaired relaxation with a compliant ventricle, whereas a shortened deceleration time either suggests a very normal and kind of snappy ventricle, or it suggests also increasing stiffness ventricle where the left atrial pressure is abnormally high. Like the E wave itself, the deceleration time correlates relatively poorly with filling pressures when preserved ejection fraction. And its interpretation, like with the E and the A wave, is generally going to be compromised in situations where you have E to A wave fusion, such as sinus tachycardia or first degree AV walls. So next, we'll spend a little bit of time talking about the tissue Doppler imaging in the mitral annulus. This is a really nice graphic that I took from one of J.O.'s slides on diastolic dysfunction, which I think highlights things very well. Firstly, we look at the TDI, or the E prime velocity, in the septal or lateral and annuluses, and it reflects LV relaxation, which is generally decreased across all grades of diastolic dysfunction and is thought to be less load dependent. When I mean less load dependent, I'm talking about the fact that it generally is less dependent on the preload, typically. It obviously, it correlates relatively poorly when there's wall motion abnormalities. Specifically, if we think about somebody with, Takotsubo, where the basal wall isn't moving quite so well, obviously that's not going to be a true reflection of the overall myocardial stiffness and the relaxation, and instead rather represent a kind of another sort of systemic process that's affecting things. Likewise, people with mitral annular calcification, prostatic valves, or also precardial diseases, these kind of mitral annular pathologies actually affect the physical properties of the mitral annulus, again, such that it is not a true reflection of the overall myocardium, but instead is a result of some sort of secondary process. Another sort of very important parameter that we use is the E to E prime ratio, which generally corrects for the effect of increasing preload on transmitral E velocity and correlates generally with increased filling pressures. And this is one of the key sort of parameters that's looked at in the most recent guidelines. And I'll have some slides talking about this in the next couple of minutes. So next, I just wanted to talk about a little bit about the pitfalls of flow-based evaluation of diastolic dysfunction. Specifically, the E and the E to A ratios generally correlate poorly with filling pressures at preserved EF because of the ability for the elevated left atrial pressures to normalize the transmitral flow. In people with reduced ejection fraction, we generally assume that the same myocardial process that causes systolic dysfunction also leads to at least grade 1 diastolic dysfunction as well. And so because of this, any elevations in your E or E to A ratio is generally going to be thought of as a direct product of your increasing left atrial pressure. Meanwhile, if we look at people with preserved ejection fraction, these people still have relatively compliant ventricles. And so despite impaired relaxation of the left ventricle, your left atrium is still actually able to elevate its increasing pressures such that your E and your E to A ratios still appear relatively normal. And so because of this, we don't know if the E to E to A ratios are normal because your heart and the diastolic function is normal, or if it's because it's pseudo-normalized by your increasing left atrial pressure. And I'll have more slides and I'll talk about this a little bit more. And so the reason specifically why E to E prime is very helpful is because of a little bit of math. And I like to kind of, I've organized this a little bit so that it makes sense, hopefully. So E prime alone is driven by impaired relaxation, whereas E, as we've talked about in some of the previous slides, is driven by both the relaxation as well as the increase in filling pressure, specifically the left atrial pressure, such that E prime is inversely proportional to tau, which is the diastolic relaxation time that we can determine through invasive sort of hemodynamics. And E is directly impacted by left atrial pressure and inversely related to tau. And so if we divide E by E prime, essentially we're canceling out the relaxation component such that E to E prime is directly a product of left atrial pressure or left ventricular filling. And so this is something that we'll talk about a little bit later when we go through the algorithms. Okay. Now, this is another topic that I just wanted to spend a little bit of time on because it took some time for me to understand why exactly the E prime is considered preload independent. And this is really, really important because we know as we go through the later guidelines that E prime is one of the first things that we look at when we assess for diastolic dysfunction. So if we look at a normal heart, the mitral annular velocity or the mitral annulus actually starts to recoil slightly before or simultaneous to the transmitral flow. So the E prime and the E are almost happening simultaneously. At that moment, when your E is actually increased, your left atrial pressure is higher than the left ventricular pressure. And so because of that, there's almost a net push, right, of the atrial pressure against that mitral annulus, such that it contributes to the E prime and the annular velocity. So in a relatively normal heart, the E prime actually is somewhat load dependent. If you volume load the normal person and you increase their preload, usually their E prime will actually go up. However, when you have somebody with an impaired heart or impaired relaxation and a prolonged tau, the ventricle actually takes a much longer time in order to actually relax. And so by the time your E prime actually reaches the impaired heart, the LV diastolic pressure has already risen or is equal to the left atrial pressure, such that in this situation, the left atrial pressure is really no longer able to augment that E prime. And so in these situations, actually, your E prime is felt to be preload independent in people with diastolic dysfunction. And one way to actually look at this is sort of in this T E minus E prime, which is one of the more novel sort of parameters that's introduced in the 2025 guidelines. Now, it's obviously not used as much in clinical practice, but I find that it's helpful to sort of conceptualize it. So the time of the E minus E prime is basically the difference between the time of the peak R to the onset of the E prime minus the time of the peak R to the onset of the E wave. So again, I'm not sure if you can actually see my my cursor here. I don't know if you can here, probably not. But as you get more and further along in diastolic dysfunction, E prime becomes later and later and later and later. The T E minus E prime becomes longer and longer and longer and longer. And this reflects in impairment in diastolic function. I won't talk about this so much in this current presentation, but this specific parameter in isolation or in relation to dividing against IVRT is actually felt to be one of the echo parameters that may be actually relatively helpful in people with mitral valve disease and annular pathology. So next, we'll talk a little bit about pulmonary vein flow as well, which is composed of the S wave, the D wave, and also the atrial regurgitation sort of wave as well, which is retrograde. When I was going through this initially, I found it relatively helpful to sort of understand what contributes to each one, and which in turn will help us understand what happens to this as we progress through diastolic dysfunction. So the S1 wave, which is the first part of the S wave, is generated by left atrial relaxation during following left atrial contraction. So if your heart is relatively snappy and your atrial properties are still relatively preserved, this corresponds to the X descent in your CVP waveform. This will generate a suction gradient as the atrium relaxes to pull blood from the pulmonary vein into the left atrium. As we undergo diastolic dysfunction, the left atrium undergoes structural remodeling, where the chronic pressure overload leads to LA dilatation and leads to fibrosis, can also lead to myocardial myocyte dysfunction as well. This directly will impact the ability of your left atrium to relax after the contraction, and thereby decreasing the gradient between the pulmonary veins as well as the LA, and subsequently causing a smaller and smaller and smaller S1 wave. On a clinical exam, this would correspond to a more blunted X descent on physical examination. Oftentimes in very, very progressive disease, S1 essentially is entirely absent or completely disappears because of changes in atrial property, or if you have atrial fibrillation that develops as a result of LA dysfunction. In contrast, the S2 is predominantly driven by RV systolic pressure that propagates and pushes blood through the pulmonary vasculature into the left atrium. But the magnitude of your S2 is oftentimes going to be dependent on your downstream pressures that it must overcome, specifically the left atrial pressure. It's also obviously going to be dependent on any transpulmonary pressures as well, which also increases that gradient as well, but that's not the focus of this presentation. As we progress throughout diastolic dysfunction, we know that left atrial pressure is generally going to be increasing. And because of that, what we're going to be doing is, again, we're going to be decreasing again that gradient that occurs between your pulmonary veins and your left atrium, such that the right ventricle has to push harder in order to get that blood into the left ventricle. And because of that, what we see is that as we progress through diastolic dysfunction, the S2 wave also becomes smaller as well as your left atrial pressure increases. The second wave that we also look at is the D wave, which generally parallel the E wave velocity. And as you can see there in the diagram, it directly overlaps with when we see the E wave on mitral CW. And this makes quite a lot of sense, right? Because the same processes that happen as the mitral valve is opening that draws blood from your left atrium into your left ventricle are the same kind of pressures that will drive blood from your pulmonary veins into your left atrium. And so as we have an increase in your E-wave velocity, we will similarly, as long as there's no problems with the mitral valve, will similarly draw blood directly into the pulmonary veins as well. And finally, we have the A-wave, which correlates directly to LA contractility and LV compliance. And the way that I like to think about it is, the left ventricle basically is the afterload with which the left atrium has to push against. And so if your left ventricle is not very, very stiff, the left atrium doesn't have to push or doesn't have to push as hard in order to get blood into the left ventricle. In contrast, as you have increasing diastolic dysfunction and increasing stiffness of the left ventricle, the left atrium must instead push harder. And so because of that, there's actually going to be regurgitant blood flow that actually goes back into the pulmonary veins rather than moving forward. This is similar and analogous to the issue of tricuspid regurgitation and pulmonary hypertension, where some of that blood flow is going to move back instead of moving forward. As we increase throughout the stage of diastolic dysfunction, and we increasing LV compliance, as I've talked about, we have a decrease in your S1 wave, we have a decrease in your S2 wave, we have an increase in your D wave, we have an increased atrial regurgitant wave, and then we also have an increase in your atrial regurgitant minus your AVE duration, because again, more of that blood flow is going back into the pulmonary veins because of the high pressures in the left ventricle rather than going forward. Finally, we'll talk a little bit about your isovolumetric relaxation time, which is the time interval between the aortic valve closure and the mitral valve opening, when the left atrial pressure increases above the left ventricle pressure. The faster the left ventricle relaxes, or the higher the left atrial pressure, the sooner that crossover happens and the shorter the IVRT. In contrast, if we have relaxation that occurs slow, or if the left atrial pressure is slow, it takes longer for that crossover to happen, and so IVRT is more prolonged. Obviously, again, the main limitation in these situations is that IVRT is also not super useful in isolation because it also is dependent on both the preload as well as the afterload. As we've talked about extensively already, the more preload that you have, the shorter the IVRT because it's compensating for the increased LV filling pressures and the increasing left ventricular stiffness. And in contrast, when you have increasing afterload, the left ventricle is essentially relaxing against a higher load. And so you actually have a prolongation of your isovolumetric relaxation time. It is, however, quite useful in mitral annular calcification, in mitral stenosis, and mitral regurgitation, because we're not looking at flows directly, nor are we looking at the properties of the mitral annulus directly either. And then the last kind of property that I'll talk about before we go through the actual algorithm is looking at the left atrial reservoir strain, which I talked about a little bit earlier as being more used in the last 5 to 10 years or so. It essentially uses 2D speckle tracking to quantify how much the left atrium can stretch and expand during ventricular systole, which is the ventricular phase. And if we go back to the Wiggers diagram that I presented kind of towards the beginning of the presentation, the left ventricular systole occurs simultaneous to the slow atrial filling that happens as we go through the cardiac cycle. In general, it's thought to represent a direct measure of atrial compliance, and such that it looks at how well the atrium is actually able to accommodate pulmonary venous flow while the mitral valve is closed. And the reason why it's useful is because it detects very subtle changes in atrial dysfunction before traditional parameters can change. And in very early stages of diastolic dysfunction, the atrium will remain largely normal in size, but its ability to deform will largely change. And so in these situations, the strain will actually slowly decrease over time before the chamber itself has actually geometrically changed. Now, there's a couple of important situations where you actually should not use it. First of all, there's also atrial fibrillation, and this makes sense because the chaotic contraction of the atrial of the atria make speckle tracking very, very difficult. We really shouldn't use it also in significant mitral regurgitation because the regurgitant jet itself can artificially increase your left atrial strain by increasing the volume that the atrium has to accommodate. It's not very useful in heart transplant recipients as well, just because, again, the atrial remodeling that can occur long-term with graft dysfunction and also immediately following the transplant process themselves. And it's also less useful in people with normal ejection fraction. Now, this took a little bit of a while for me to understand, but in general, a lot of the left atrial reservoir strain is actually because of the ventricular contraction. And so if we have somebody with a preserved ejection fraction, the ventricular contraction is still preserved, so you can still strain and stress the left atrium. And in this case, the left atrial reservoir strain is no longer a reflection of the intrinsic properties of the left atrium, but instead can actually be influenced by the contraction of the left ventricle. Finally, it also shouldn't be used in people with GLSs that are also significantly impaired as well. And because, again, this represents a global process rather than something directly wrong with the kind of the diastolic function itself. Now, the reason why it's not used as often, and I'm sure some of the echo staff here could talk about this a little bit more, is because there's a lack of standardization, and it also requires very specific algorithms by the machine itself to actually use this. But hopefully in the future, as different vendors, kind of coordinate, we can actually use this a little bit more. And currently, this represents sort of a secondary value that we look at when we look at diastolic function. So now that we've gotten all of this through the way, we can actually talk a little bit about the different stages of diastolic dysfunction. Previously, there were multiple grades of diastolic dysfunction, whereas now we just break it down into 3 different phases of impaired relaxation, pseudonormalization, and also restrictive filling as well. And the way that I like to think about it is sort of a gradual progression of LV suction to LV push, LA push that guides LV filling. Specifically, in normal physiology, the predominant process, as we've already talked about, that drives blood from your left atrium to your left ventricle is the active relaxation of your left ventricle that subsequently sucks blood from your left atrium to your left ventricle. As we progress and have impaired relaxation, you subsequently have an increase in your left atrial pressure or your left atrial push to push blood into the left ventricle that is no longer sucking blood appropriately. And so this is kind of like a way to kind of conceptualize the different changes that occur as we go through grade 1 to grade 3 diastolic function. So first, we'll look at normal diastolic function, and hopefully this will go relatively quickly now that we've already talked about all the different echo parameters. So in normal diastolic function, we have a very snappy ventricle that can relax actively. And so because of that, we have a high E wave and a low A wave, meaning that the relative contribution of early diastolic filling is high, and the atrial kick contributes a relatively low amount of the diastolic filling. In these situations, the E/A ratio is felt to be between 0.8 to around 2. Because your LV relaxation is still relatively preserved, your E prime wave will be much higher than your A prime wave, which corresponds to the atrial kick. And compared to the ratio, which again represents your left atrial pressure, your E divided by your E prime will be much less than 8, because will be less than 8 because your E prime is still relatively high, and so your ratio is going to be relatively low. Looking at your deceleration time, because your left ventricle is still relatively snappy, it will be between 150 to 220 milliseconds. And relatedly, the isovolumetric relaxation time is going to be relatively short, between 70 to 90 milliseconds. If we look at the pulmonary vein flows, we see that the S wave is going to be significantly bigger than your D wave. And the reason for this is because, as we remember, your S1 wave is predominantly going to be determined by the relaxation of your left atrium. And so if your left atrium is going to be able to relax strongly, then we have a pulling force that pulls blood from your pulmonary veins into your left atrium. And for the S2, we also have a very high E wave, but we also have a correspondingly high S2 wave as well. And the D wave represents the E wave, and so has a less contribution compared to the S wave. It's important to note that prognostically relevant changes and alterations in your diastology can occur in normal values. And so because of this, it's relatively important to consider all of these different factors in unison rather than looking at them in isolation to determine which patients are going to be most susceptible to clinical sort of morbidity down the road. So, let's try to walk through grade 1 diastolic dysfunction, and hopefully this makes a little bit, quite intuitive sense since I've already talked about each of the parameters sort of in isolation. This represents relatively the earliest stage, and the key concept here, as I've talked about already, is that the relaxation is impaired, but your left atrial pressure is still normal. And that's the distinction that sort of drives every single parameter that we talk about in this slide. So first, if we look at the mitral inflow, the E wave is lower than the A wave and therefore you have an E to A ratio that's less than 0.8. This is because the ventricle is relaxing relatively slowly. It doesn't generate a strong early suction gradient that pulls blood across the mitral valve, and so the E wave drops. In order to compensate, and also because there's more blood left in the atrium, you have Frank-Starling forces that occur, causing a bigger and bigger A wave. Because of that, your E to A ratio will also drop. If we look at the tissue Doppler, the A wave, or the A prime, is actually going to be significantly greater than the E prime, which sort of reflects a similar story as when we look at the flows themselves. So the early myocardial relaxation in this situation is sluggish, so the annulus doesn't move quite so much compared to its degree of movement during atrial contraction. And so when we divide the two different ratios, when we look at the E over the E prime, it becomes less than 8. Because, in spite of impaired relaxation, the filling pressures are still low, and so the E to E prime ratio is still going to be relatively low. And if we go back to that slide that I had a little bit earlier, remember that the E to E prime is our best and non-invasive surrogate of LV filling pressure, such that you have low E wave, low E prime, so the ratio is still relatively normal compared to what we were looking at earlier. Now, if we look at deceleration time, your deceleration time is going to be relatively prolonged. And this makes sense because of the slow relaxation and your relatively low left atrial pressures that are not compensating quite yet. And so because of this, the blood is almost trickling across the mitral valve rather than being pushed or pulled through. And so your E wave just simply takes much longer time to decelerate. If we look at the isovolumetric relaxation time, it's going to be prolonged. Again, because your left ventricle is relaxing slowly, so it takes longer for the LV pressure to drop below the LA pressure and open the mitral valve. And because your left atrial pressure is still normal, there's no left atrial pressure to accelerate that crossover that actually happens. And then finally, if you look at your pulmonary vein flow, your S wave is going to be much greater than your D wave in this situation. Because during systole, the atrium is still relatively compliant and it relaxes. And so because of this, it can still feel relatively easily from the pulmonary veins, thus causing a big S wave. However, because we see that the E wave is lower in grade 1 diastolic dysfunction, similarly, the D wave is also going to be lower as well. And this is what predominantly drives, this difference in your S wave and your E wave and S wave and your D wave in this situation. Okay, so if we move now to grade 2 dysfunction, this is pseudonormal filling, which is probably the most difficult pattern to sort of recognize. Now, the key concept here is that we have increased left atrial pressure that is compensated to normalize the LA to LV gradient. What this means is that your left atrium has raised its pressure just enough such that it restores a relatively normal-looking transmitral gradient. So the mitral inflow pattern looks deceptively normal, even though the underlying relaxation that's supposed to drive this process is still impaired. So if we start first by looking at your mitral inflow, your E wave is higher and your A wave is lower, and the E to A ratio is less than 2. Remember, if we go back to the first stage in grade 1 diastolic dysfunction, the E wave is low because the ventricle isn't relaxing well and the left atrium pressure is relatively normal. Now, the LA pressure has risen to compensate, and so it restores that relatively early filling that happens during your CW across the mitral valve. And so the E wave comes up, not necessarily because the relaxation has improved, but because, again, the left atrium is pushing harder. The A wave subsequently will drop because the atrium is starting to lose some of the contractile reserve against a stiffer ventricle, and also because most of that filling has already occurred and the emptying of the left atrium has already occurred. Now, if we look at what will actually unmask the underlying pseudonormalization, we look at, obviously the tissue Dopplers as well. The A prime in this situation is still going to be greater or equal to your E prime because the myocardium is still relaxing relatively poorly. This itself has not changed compared to grade 1 diastolic dysfunction. But now, because of the inherent changes in terms of your E versus your E prime, remember your E is normal, but your E prime has dropped. And so because of this, what happens is your E to E prime is going to be slightly higher compared to grade 1 diastolic dysfunction. So as that ratio climbs higher and higher and becomes less than 8, this is your first clue that left atrial pressure is not completely normal. Now, if we look at pulmonary vein flow, your S wave is now less than your D wave. The reason for this is because of the rising left atrial pressures that start to impede your systolic filling of the atrium from the pulmonary veins. So the gradient that happens during systole between your pulmonary veins and your left atrium is smaller, and so because of that, your S wave is going to become smaller as well. Meanwhile, your D wave is actually going to become bigger compared to grade 1 diastolic dysfunction because of the normalization of your left atrial pressure. And remember, your D wave corresponds directly to your E wave. And so you almost have an increase in the size of your D wave compared to the S wave. And this is, again, also another one of the supplemental markers that we'll look at when we go through the algorithms a little bit later. And so the overall teaching point here in grade 2 is that even though your mitral inflow seems normal or pseudo-normal, the tissue Doppler, your E over E prime ratio, and your pulmonary vein flow all suggest that your relaxation is impaired and now your left atrial pressure is rising. And so this is the stage where we have to look outside of your E to A ratios in order to determine a diastolic function. Okay. So, this is another thing that I wanted to quickly talk about, just in terms of understanding the underlying physiology of, pseudo-normalization. So what we can oftentimes do, and we don't do this clinically very often, but it makes sense physiologically, is that, the pseudo-normalization happens because of your increasing left atrial pressure. And so if we can somehow do something to decrease your left atrial pressure, then we can unmask a grade 1 diastolic pattern where we have your E to A ratio less than 0.8. So what we can do is we can get the patient to bear down against a closed glottis for about 10 to 12 seconds. And then we look at the transmitral inflow that's measured specifically at PW. As we bear down, what we're doing is we're increasing intrathoracic pressure. We decrease your preload, and you also decrease your left atrial pressure. Now, if we're decreasing left atrial pressure, then the only thing now that actually drives that E wave is going to be the LV relaxation. And so subsequently, we can actually unmask that grade 1 pattern. And so it's generally thought that a decrease in your E to A ratio of greater than 50%, or if you have an increase in your A wave, this is thought to be highly specific for increased filling pressure. Okay? So again, this is not something that is used very often clinically, but it's quite helpful in terms of understanding what happened with grade 2 diastolic dysfunction. Finally, we have grade 3 dysfunction, which is a restricted filling phase. So in this situation, we basically have an exaggeration of what happens with grade 2 dysfunction. We have worsening LV compliance and also increasing left atrial pressure, such that LAP is so high that we actually have an even higher A wave. And we also start to get left atrial dysfunction such that your A wave becomes smaller. Your E to A ratio in these situations is going to be greater than 2. And we have a high A prime wave, which is going to be equal or greater to your E prime wave. Because your E wave is so high and your E prime wave is so small, what we're going to get is an increase in your E to E prime ratio greater than 14, which is one of the hallmarks of increasing left atrial pressure. And your deceleration time, because of the stiffness of the heart, but also because of the high left atrial pressures, is going to be very short. And relatedly, your isovolumetric relaxation time is also going to be very short as well. Finally, your S wave is going to be smaller than your D wave because, again, a lot of that inflow is going to be driven by your E wave, and your LA pressures are very, very high, such that the gradient during systole between your pulmonary veins and your left atrium is going to be relatively low. So this is a chart that I made just to go back to, which kind of summarizes each of these parameters, what it predominantly assesses, what the normal values are, and what the values that kind of occur as we go through grade 1 to grade 2 dysfunction. And hopefully it's can be useful for other people moving forward as we're trying to remember what each of these parameters mean. So putting it together, I'll spend the last kind of 5 minutes talking about the actual guidelines themselves, which were updated last year in July of 2025. The previous guidelines were published in 2016. And the whole purpose of the guidelines is to try to reduce the number of people that were previously classified as indeterminate diastolic dysfunction. Such that now, if we go through the current guidelines, understanding the key caveats, almost nobody will be ever classified as indeterminate diastolic function, and almost quite few people are going to require invasive or exercise echocardiography to assess diastolic dysfunction. So the general steps are, first, you look at your E prime as a marker of LV relaxation. After that, you also then look for markers of left atrial or left ventricular remodeling and left atrial pressure by looking at your E over E prime. You're looking at your left atrial reservoir strain, less than 18. You look at your E to A ratio, either very, very low, representing a grade 1 diastolic function or impaired relaxation phase, or very, very high, representing a restricting filling phase. Or you look at your left atrial volume index as greater than 34 as a representation of chronically elevated left atrial pressures. So in general, if we have E prime, that being relatively low, we only need one of those kind of 4 markers present in step 2 in order to diagnose diastolic dysfunction. Whereas if E prime is preserved, then we need 2 or more of those functions, 2 or more of those parameters described in step 2 in order to diagnose diastolic dysfunction. Now, this is the famous, table that I think all of us have looked at probably, many, many, many times. And I'll try to walk through this kind of from the left and then subsequently to the right. So on the most left side, we see, so first, I think we should look at the 3 parameters that they look at first. So those being your E prime velocity, septal less than 6, or lateral less than 7, or an average of less than 6.5. Increased E over E prime ratio, or septal greater than 15, and the lateral greater than 13, or average greater than 14, which again represents your left atrial pressure elevation, or your increasing TR velocity greater than 2.5, or when you can also assess your RAP, or pulmonary artery systolic pressure greater than 35, which again is representation of increasing LA pressure. So if all of these functions are normal, then we can very, very easily say that your left atrial pressures is normal, so you have normal diastolic function. In the second box there, we see if your E prime is reduced, we say that there's a suggestion that your LV relaxation is impaired. So then we go to look at your E over A ratio. If your E over A ratio is less than 0.8, then it's very, very easy, right? Because we see that because we know in this situation that your E prime is low and your A prime is relatively high. Your A is relatively high. The only situation where this will happen is when your left atrial pressure is normal. Because if your left atrial pressure is high, as we remember, that high left atrial pressure will normalize your E wave and cause your A wave to become smaller. And so if your E to A is less than or equal to 0.8, we can say it's normal left atrial pressure and we have grade 1 dysfunction. Now, the challenging thing becomes when your E to A ratio is greater than 0.8, because we have 2 patients within that are in sort of 2 different buckets. On one hand, it may be the bucket that the patient is pseudo-normalized because you're increasing left atrial pressure, and the other bucket is the patient who just has impaired relaxation. And so the next bucket, the next box that we have to look at is the purple box, where we try to evaluate whether or not there is or isn't increasing left atrial pressure. One of the ways that we can look at this is your S over your D ratio less than 0.66, which again should typically have a higher S compared to D, but in diastolic dysfunction, because you're increasing left atrial pressure, your D becomes higher than S, so you have a ratio that's less than 0.66. The other thing that we can also look at is your left atrial reservoir strain that is less than 18, or your left atrial volume index, which is greater than or greater than 34, reflecting chronically elevated left atrial pressures. Finally, the other thing that we can also look at is your IVRT less than 70 seconds. Now, if we remember, a typical IVRT is typically on the lower side. But if we have an even lower IVRT less than 70 seconds, this is probably considered too fast, and generally can be thought of as being only a product of increasing left atrial pressure. And so if all of these factors in the purple box are not positive, we can say quite confidently that your left atrial pressure is normal. And so because of that, we just have grade 1 dysfunction. If any of those purple box parameters are high, then we can say that the left atrial pressures are high, and we look only at your E over A ratio, where if your E over A ratio is less than 2, then we say it's grade 2 dysfunction, whereas if your E to A ratio is greater or equal to 2, then we have grade 3 dysfunction. Now, if we look at the third box we see, if we have increased TR or PASP only, or if we have an increased E over E prime only, or any of those two abnormal variables, we similarly will go into that purple box because there's not enough factors to confidently say that both your relaxation and your left atrial pressures are high. Now, in the top sort of right-hand corner, we see very specific situations where we can't use this normal algorithm. And I quickly created a slide here just to talk about each of these parameters and why we can't use each of those the standard algorithm. If we look on the St. Mike's YouTube site, there's also other presentations that have been done in the past looking specifically at diastolic dysfunction in the context of each of these situations. So I won't spend too much time going through this in detail. However, in people with MAC, in general, they have restricted annular motion that artificially limits your E prime, and also simultaneously the decreased mitral orifice will artificially increase your E velocity, making your E over E prime falsely elevated. And people with mitral regurg, they have chronically elevated left atrial pressures, which blunts your pulmonary vein systolic flow, which increasing your left atrial pressure. And this can also mimic a pseudonormal or restricted pattern, even if your left atrial pressure is normal. People with mitral stenosis, obviously the stenotic valve itself, rather than the myocardium, is actually increasing your left atrial pressure, which in turn can increase your E prime and also decreasing your IVRT. Again, also mimicking a pseudonormal to restrictive pattern, even with normal left atrial pressure. Obviously, in people with atrial fibrillation, the beat to beat variability and the loss of atrial contraction basically eliminates the A wave and makes the E to A ratio and the atrial regurgitation minus the A duration unmeasurable. In people with LVAD, there's a continuous unloading of the left ventricle, and it is also represented by increasing beat to beat variability in the transmitral flow. So the relationship between mitral inflow and true filling pressures is not truly dependent on the myocardium, but instead dependent on the pump speed. In people with non-cardiac pulmonary hypertension, the elevated TR velocity is going to be a reflection of the pulmonary vascular resistance and the pulmonary vascular disease intrinsic to the pulmonary vascular circulation rather than elevated left atrial pressures. People with heart transplant, you can have denervation that causes tachycardia and the issues of E to A fusion and the augmentation of the A wave, which we talked about earlier. In people with young donor hearts, they can actually have a normal ratio of E to A that's greater than 2, that mimics restrictive physiology that doesn't really represent what's going on in reality. And then finally, in pericardial constriction, you have this idea of annulus paradoxus or annulus reversus as well, whereby the pericardium and the restriction of the pericardium actually causes an exaggerated LV annular velocity despite actually having impaired LV filling, such that your your E prime is going to be relatively high, even though your filling is going to be impaired. And then relatedly, you also have this annulus reversus phenomenon where your E prime is going to be less than your septal E prime because of the restriction that happens with the pericardium. And so finally, I'll spend 10 seconds talking about the changes that have occurred in the 2025, because I acknowledge I've been talking for 55 minutes. So the first thing is looking at a stepwise approach for supplemental variables to eliminate the indeterminate category, which represented between 20 to 30% of patients that we kind of looked at when we looked at the 2016 guidelines. We also started to look at your left atrial volume index in the second stage rather than the first stage of determining LV diastolic function, because we know of all the different factors that can affect LV volume index independent of diastolic dysfunction. And then finally, we also have the addition of your left atrial reservoir strain less than 18 as a surrogate for elevated diastolic pressure, although again, its utility broadly is less used. And I think that's about it. I acknowledge that I've been talking for quite some time for a very difficult topic, but happy to kind of address any questions. Thank you.